Hello! If you're managing patients in the hospital, you know firsthand that getting blood glucose under control isn't just a number of a chart. It's a critical factor that directly impacts patient outcomes. Today, we're going to walk through the newest evidence-based standards for tackling this challenge. Welcome to the Dr. Emek Explainer series. In this explainer, we're focusing on the key updates from the American Diabetes Association's 2025 Standards of Care for the Hospitalized Patient. Just a reminder, this information is intended for educational purposes and should never replace your independent clinical judgment. All the information we're covering today is taken from the following sources. All right, here's our roadmap. We'll start with why this is all so critical. Then, we'll cover initial assessment and goals, modern treatment strategies, how to handle some high-risk situations, and finally, how to ensure a safe transition back home. So, let's start with Section 1, the stakes. We all know that dysglycemia is linked to poor outcomes, but the flip side is just as important. Getting this right with proactive, smart management can actually shorten hospital stays and, crucially, reduce those frustrating readmission rates. Moving on to Section 2, assessment and glycemic goals. What we do in those first few hours sets the stage for the entire hospital course. There are two things we absolutely have to get right from the start: confirming the patient's glycemic history and setting clear, evidence-based glucose targets. These initial assessments are foundational. The ADA is clear. Get an A1C on any patient with known diabetes or glucose over 140 unless they've had one in the last 3 months. Why? Because an A1C of 6.5% or higher tells you this isn't just stress hyperglycemia. You're dealing with pre-existing diabetes. It's also vital to quickly gauge their self-management skills. This isn't just for discharge planning. It informs how you'll manage them right now. Now, let's talk targets. The standards are very specific here. For our sickest patients in the ICU, we're aiming for a range of 140 to 180. For our non-critically ill patients on the floor, we have a slightly wider goal of 100 to 180. The key thing here is that tighter is not always better. Many of us will remember the landmark NICE sugar trial, which proved that trying to push glucose down to the 81 to 108 range actually increased mortality. So these more moderate targets are a direct reflection of that high-quality evidence. And to make sure we're all speaking the same language, the ADA has standardized the definitions of hypoglycemia. Level 1, between 54 and 69, is your alert value, time to act. Level 2, anything below 54, is clinically significant hypoglycemia. And level 3 isn't a number, it's a clinical event where the patient needs help to recover. Okay, so we have our targets. How do we actually hit them safely and effectively? That brings us to Section 3, modern management strategies. We're really going to focus on the shift toward proactive, more physiologic insulin approaches. If there's one recommendation to burn into your memory, it's this one. The old-school sliding scale used as the only method of insulin therapy is strongly discouraged. It's a purely reactive strategy. You're always chasing high blood sugars instead of preventing them. We have solid randomized trial data showing that proactive basal bolus regimens lead to better glucose control and, more importantly, fewer hospital complications. And this really illustrates the core difference. Basal bolus is proactive. You're covering the patient's background needs with basal, their mealtime needs with prandial, and then you have correction on top. The sliding scale is purely reactive. It does nothing until the glucose is already high. That's why basal bolus is the standard of care for most of our inpatients who are eating. Of course, for our most critically ill patients, we often start with an IV insulin infusion for that minute-to-minute control. But this sets up a very common and very high-risk clinical scenario. How do we get them off the drip and onto subcutaneous insulin without sending their glucose skyrocketing or even pushing them into DKA? The protocol is straightforward, but the timing is absolutely everything. First, you give the subcutaneous basal insulin. Then, and this is the part people miss, you wait 2 full hours before you shut off the IV drip. That 2-hour overlap is non-negotiable. It prevents that dangerous gap in insulin coverage that leads to rebound hyperglycemia. Just a quick reminder, you are watching the Dr. Emek Explainer series. All right, let's get into Section 4, where we'll navigate some of the trickiest situations we face, managing patients around surgery and dealing with full-blown hyperglycemic crises. Perioperative management requires precision. SGLT2 inhibitors have to be stopped 3 to 4 days beforehand because of the risk of euglycemic DKA. Metformin is held on the day of surgery. Most other orals are held that morning. And we typically reduce the basal insulin dose, often by 20 to 25% for long-acting insulins, to prevent hypoglycemia while they're NPO. GLP-1 agonists are also held, really due to concerns about delayed gastric emptying. Now, for a true hyperglycemic emergency like DKA or HHS, our response boils down to 3 core pillars. First and foremost, aggressive IV fluids to restore volume. Second, an insulin infusion to shut down ketone production and bring down the glucose. And third, and this is critically important, meticulous electrolyte replacement, paying very close attention to potassium. And that brings us to our final section, Section 5, ensuring a safe discharge. We've stabilized the patient, we've managed the acute issues, and now we face what is arguably one of the most critical steps, creating a solid plan to get them home safely and keep them there. A safe discharge plan has several key components. It starts with a painstaking medication reconciliation. It requires clear, prompt communication with the outpatient provider. Get that discharge summary to them quickly. It means scheduling a follow-up visit within a month, or even within 1 to 2 weeks if you've made major changes. And finally, it demands real patient education on sick day rules, their meds, and especially how to handle hypoglycemia. This whole package is a powerful strategy to prevent readmissions.
You are watching the Dr. Mech Explainer series. If you found this clinical breakdown useful, please take a moment to subscribe and enable notifications so you don't miss our future updates. So, to sum it all up, the 2025 ADA standards really double down on a proactive, evidence-based, and systems-oriented approach to inpatient diabetes care. And that leaves us with a final thought. As technology like predictive AI and automated insulin delivery continues to evolve, how will these tools fundamentally transform how we manage glucose in the hospital and improve patient safety in the years to come?